and welcome to the second episode of Let's Dissect. Care in oncology extends well beyond the walls of the OPD and the operating theatre. Our patients face a myriad of challenges, which may range from financial issues, poor social support, cosmetic and functional morbidities, and the inability to return to school or work. As cancer care providers, uh, our ability or our team's ability to battle these challenges on behalf of our patients really contributes to the success of treatment just as much as any new drug over the counter. And for a clinician like me, this can sometimes feel like an overwhelming task. And so today we have the unique opportunity to dive into the inspiring story of somebody who has really helped ease the social burden associated with pediatric cancers. And we are very privileged to have with us Dr. Banavali sir. Sir is a pediatric oncologist from Tata Memorial Hospital, Parel. Sir has served as the head of department of the Departments of Medical Oncology and Pediatric Oncology, as well as Dean Academics throughout his career. So thank you so much for joining us here today. Your journey back to the Department of Pediatric Oncology has been very exciting and action-packed, sir. So I wanted to know, were you always interested in working with children, or was there an incident which sparked your interest?
First of all, thank you for having me on this podcast. So I'll correct it a little bit because I did my MBBS. After that, I did my MD in internal medicine, and I was working with Dr. M.B. Agarwal, who is one of the fathers of hematology, benign hematology in the country. So while working with him, actually, he suggested that why don't I go for 6 months to Tata Memorial Hospital. This was in Sion Hospital in Mumbai, Lokmanya Tilak Municipal Medical College and Hospital. So from there he made me go to Tata. It was for 6 months to learn so-called hot hematology. That means treatment of leukemias and all. That was way back in '87. And that time I came for 6 months. I was supposed to work in Tata, and that has been nearly more than 40 years now. So it's a long story, but what I wanted to tell was I did my adult medicine first, then I did my adult hematology under Dr. S.H. Advani at Tata Hospital. And while I was working at Tata Hospital, we used to take care of pediatric patients also. And most of the pediatric patients in the country, I'm talking about in 80s, were treated by adult oncologists only. So though we say children are not small adults, unfortunately at that time there were very handful, not even a handful of people who were trained pediatric oncologists in the country. And after looking at the number of patients that we had in Tata and the outcomes, I thought that since the country wanted a trained pediatric oncologist, when I got to, actually from Tata, I went to United States in University of Cincinnati to work on basically stem cells at that time, which was a very, very new subject. So I was working there, and after I did my full lab work, 3 years, I worked in the lab on stem cells, which was CD34 stem cell, very new. So when I finished that, when I wanted to come back, I thought, why not do my pediatric oncology also? So, and the only center I wanted to work was St. Jude's Children's Cancer Center, which is supposed to be the mecca of pediatric oncology. When I inquired there, they told, unless you are a pediatrician, we cannot take you. So MD medicine or adult oncology training doesn't help here. So I actually found out St. Jude's was in Memphis at that time, which is a very, very, actually, won't say it's not a that developed area of USA, but I saw on the map that in St. Jude was in Memphis, and in Memphis there was only one pediatric program, which was Lebanon's. So I went to Lebanon, did my board certification in pediatrics, then did my 3 years in pediatric oncology fellowship at St. Jude's, and then came back to the country. So it was a very long journey,
Yes, sir.
but a very fulfilling journey.
So about St. Jude's, we know it is a very prestigious institution. So we have heard here in India that all patients there are enrolled in a trial and they are all treated free of cost. Is that true?
It's very true. Actually, to tell you the truth, actually St. Jude's, they have a LSEC. There's an arm which just raises funds for St. Jude's. and they, for example, last year maybe raised more than or nearly $2 billion in 1 year. So basically, they raise more funds than the American Cancer Society. Can imagine that this is only for pediatric cancer. So having been trained in St. Jude's, actually I could see that basically their patients, what happens is there are in USA there's a different system. Many of the patients from the country have a insurance. So those who are covered by insurance, the insurance takes care. Anything above the insurance, if the family cannot afford, it's done free. And they take patients from all over the world if they are fitting into the the projects or the the studies that they are ongoing. So if they fit into that, they accept the children from all over the world, and not only they treat these children free of charge, but they also arrange for their accommodation, they arrange for their travel, they send tickets, air tickets also to for the children to come for follow-ups and all. So yeah, that is what is done at St. Jude, and they really do that well. So that's what I learned when I was at St. Jude's.
So, so you also spoke about Dr. Suresh Advani, sir.
Yeah.
So he is a very well-known, renowned medical oncologist, and we have all heard of him. Sir, what role has he played in your journey?
See, I can talk for hours on this person, but Dr. Saisesh Advani, as you know, is the father of medical oncology for the country. But, I was very fortunate to even spend some, practice in the same room where he used to sit patient. And since there was shortage of space when I came back, he was gracious enough to allow me to see patients in his room only. So I will tell basically not to learn oncology from him, but to learn how to take care of patients. So he will tell, just listen to me, see how I talk with the patient, how I basically deal with the patient. And I'll tell you, we have learned so much to how to give hope. He will always say that if you cannot give, if you cannot give hope, you have no right to take away hope from the patient. And he will always say positive things about how bad the disease is, but he will always give the positive picture to the patients, the relatives, and touching the patient. He will just will see. Even patients used to wait for hours just to get one touch of his. He will just touch the patient, tell him ठीक हो जाएगा, and for that one dialogue of that, they would wait for us. So we have learned so much more than oncology from Dr. Advani, and he would always find ways. If there are standard treatments that failed, he will think about alternative methods, different treatment, but he would never, unless the patient was very bad, he will try to treat as per the needs of the patients, their financial distance. So we learned a lot from Dr. Advani, not only oncology but also humanity, and really how to deal with the patients. So that was a big learning that you cannot learn from any books or any basically watching videos or this thing, that you have to learn by just sitting with the legend and see how he deals with the patient.
So it sounds very inspiring. I also wish that I one day have an opportunity to meet him.
I think, and he never bothered whether the patient was general patient, private patient, this thing, all patients were same to him. It was not even like there was to be patients waiting outside. He will just, why are they waiting? And you tell that the other consultant has still not come or is busy, he's not there. He will call all the patients, they will finish the patient before that consultant came also. So it was never your patient, my patient, I've seen already this patient, or this is private patient. So a lot of things we learned from sir that has helped us take care of patients over the years now.
So you mentioned that you went to Cincinnati to work for a research project. So we found online that you had written this protocol and you got selected for a fellowship. So how was that experience? And did the research question that you asked turn into fruition?
Absolutely. So, that again, Dr. Advani has played a major role because, see, after I finished full my 3 years of oncology fellowship at that time. And, everyone, so Dr. Advani had one rule that all his residents should go abroad. So 14 or 17 of the residents during the 3 years that I was there, except for one or two, all the other residents we have gone abroad. many have stayed back and not come, but a few of us have come back also and have done really great. But his this thing was we should go abroad. So what happened was I got a call from Royal Marsden in UK to come and work, which I went there to ask him basically that I've got a position, should I go? And he absolutely was this, UK and US, there's big difference. There's a lot of new things happening in US. The UK is like India. A lot of clinical work, great this thing, but more of clinical. You'll not be exposed to new ideas, new this thing. So no, don't go. Wait to go to US only. And everyone laughed at me. We're getting opportunity from Royal Marsden, which is again one of the great institutions. But he told no, and since he told no, I did not. I told we'll go. And then I wrote this project where in chronic myeloid leukemia, all of these patients go from chronic phase to accelerated phase and to blast crisis. Blast crisis at that time was even today actually, it's a non-treatable condition, and basically you just see how it progresses. Eventually, in 100% of patients, is to progress from chronic phase to blast crisis. And I wrote a project how this happens and how the stem cells that are this thing which accumulate and over time then the stem cell which is a slow growing population and the more differentiated cell the fast growing population. So the fast growing grow first, but the stem cells slowly start growing and then they reach basically the phase where you eventually enter blast crisis. And luckily for me, there is a molecule called CD34, which is a stem cell marker that first time came into the market. At Kurt Sieben, who is a pediatrician, actually the pediatric oncologist at Boston, who discovered this CD34 molecule, it came in the market. So but it was still under this thing. So what I proposed was, if you do this CD34 and mark the label the stem cell in chronic phase and in accelerated and blast crisis, you should see that this stem cell or CD34 population keeps on growing. And I told him, okay, I sent it to Dr. Harvey Preisler, who is the father of acute myeloid leukemia treatment in the world. Even today, his protocols are used. And he used to work on CML also. So I sent it to him, ki, you think you can, this is possible, you can do so. He told, why you think? You come and work on this and see whether it is there. So I went to US and we would basically we started working on this CML and this CD34, and it beautifully showed that in chronic phase it is 5-7%, in accelerated phase goes to 10-14%, and then in blast phases goes to more than 25% of this thing. And it was my first paper in say from US, where which we published in Leukemia, one of the very good journal of basically this thing, where we showed that chronic to accelerated to blast crisis, the stem cells grow, and that's how they enter in the sense. So that's how I went there and worked in a lab which was working on this acute myeloid leukemia and chronic myeloid leukemia, and did a lot of work in the lab there.
So, sir, your term in the US was a success and you were associated with such prestigious institutions.
Yeah.
So, what made you come back to India?
Yeah. So, so basically when I finished my 3 years of, see, I had gone from, say, Tata only to US. At Tata, when I was just leaving before that, they had already, actually Dr. P.V. Desai was the director that time, had already announced that we are going to develop ACTRAC, which is Advanced Center for Cancer Treatment, Research and Education, basically in Navi Mumbai. That was going to start. He unveiled the plans also, and it was there that it will take 2-3 years. So Dr. Advani told me, by the time this center is built, why don't you go there? And no clinical. We had worked enough clinical in Tata, so it will go and work in the labs and come back. So I went there, worked with the stem cell. I was lucky enough to be one of the first groups in the world to work on this CD34 stem cell, because we developed a method also how to isolate using the the magnetic beads, how to isolate this stem cell, and then worked on the stem cells there. But after 3 years, actually, I used to keep on asking, and the at Tata, unfortunately, because of various politics, actually the extract did not materialize. So I told her 3 years is long enough. Let me come back. So I told I'll come back. But my boss there, Dr. Harvey Preisler, again, who is, I told you, father of acute myeloid leukemia, he told me, Shripad, if you go back now, India, they won't recognize your lab work because that's not, you have to do something clinical if they want to recognize your work. And then basically, I thought if this thing, I had already done my adult oncology in the country. So I told, why don't I do, since there was a dearth of pediatric oncologists that time, I changed my branches. And like I told you, I had approached St. Jude's and they told me unless you do pediatrics, you cannot do pediatric oncology. So I did my board certification in pediatrics and then in pediatric oncology. And the day I finished my training, a 3 year fellowship in pediatric oncology, the next flight I was back in the country. So I always wanted to come back. And luckily for me, sometimes you want to come back, but your wife don't want to come back and all. But luckily for me, more than me, my wife wanted to come back. So we both basically came back. And then I was very, very lucky that the day I joined, actually, I told my wife we'll take a month break and then I'll join. But the Dr. Advani again made me join literally the next day. And immediately I joined Tata and I'm here for last, I don't know, 38 years now. I'm back in Tata for since 1987 I joined. In between 8 years I was in US, but to date I'm in Tata for the last so many years.
So when you came back, was it difficult to get back into the routine of things, or was there a very stark difference that you noted?
Yeah, no, there's a lot of difference, but luckily, like I told you, see, people who have not worked at a place, they go and then they work in the best, and then come back, they find it difficult. But luckily for me, I was in Tata for 3 years. The not only the doctors, my colleagues knew me, but I knew the nurses, the pod boys, the staff, everyone knew me, and they were so happy to get me back. So I was very lucky that the people, and I was a resident that time. When I was resident, there were 2 or 3 residents only in the department. So I used to be on call literally for 3 months in a row. I have taken night call 3 months in a row. I have signed more than 100 consecutive death certificates at Tata because there was no people, only one. So the nurses, the doctors, the ward boys, everyone knew me. So it was very good for me to come back, and I joined Tata on a good note. So it was, so it is, I wouldn't say it is a cakewalk, because see, when I went to St. Jude and when I worked in US, you used to take 2 3 hours to talk to a patient. The first time the patient comes, by the time you take history, talk to them, review the reports with them, it takes at least 2 3 years. So when I came back, and you have to listen to this story. So when I came back, the Maushi, the ward boy, the lady who runs the OPD was the same. So when I came back, I used to talk to the patients more, and then the patients will get piled up outside. One day she came, this thing, she literally closed the door, sat down, and told me, "What has happened to you? Dr. Banavali, we thought we have sent you to US to become better and come. You have become worse. You are taking more time to see patients than what we did before." And literally, so they are not used to it. So we are used to talking. So I had to then think about what is happening outside also, and slowly came back to the groove, came back to the Tata methods of seeing patient. But people were very helpful, and they were so good close that they could even talk to me like that, this thing. So I had a great time, great this thing. So I never felt out of water or something. But one thing I saw, this I'll tell you, the most important thing that happened to me, that in St. Jude's or in US, no patient is told no. Like any patient that comes is treated. If you have insurance, insurance. If not, also you treat, and then we'll see how to recover this thing. But we say no. I came back from USA. You'll not believe. There were many places. See, this is before the scheme era and all. Ayushman Bharat, Mahatma Jyotiba, all these government schemes were not there in 87, in 97 that I came back. There were no such schemes, and patient used to it. So even though Tata is a government hospital, lot of infrastructure is free. Means doctors, there's no consultation fee or no admission charges, or no basically x-rays. But for the medicine, the patient had to buy the medicine, patient had to do the diagnostic test. So for that you required money. There was no, so even if you do the full treatment free, Patients had to stay in Mumbai for whatever time, and that takes more money than treating. So they may have money to treat, but where will they stay? Bombay is such an expensive place to stay. They had no food to eat. So I saw that many patients who are highly curable cancers. I mean, I've learned everything there. I've come back. I'm in a position to treat, but I couldn't treat because they couldn't stay in Mumbai, or they couldn't afford the treatment. Or very, very importantly, you'll see I had patients who could afford the treatment, afford to stay, but they did not have blood and platelet donors. So if we at that time, I'm talking about in 90s, if we did not, the patient couldn't arrange for blood and platelet donors, and many of the pediatric cancers, especially blood cancers, see, commonest cancer in pediatrics is leukemia lymphomas. So if you couldn't arrange for blood and platelet donors, we couldn't treat the patients. We had to tell them, no, we cannot treat because you don't have blood platelet donors. So we have sent patients who couldn't arrange for blood and platelet donors. And that time I really felt that we need to do something, because you know how to treat. These are highly curable cancers, but you cannot treat because of these things or this limitation. And that was making me very, very worried. What am I doing? And whether I've taken the right decision of coming back. But definitely we, instead of questioning the system, we thought, see, government was doing out of the way. The Tata, as you know, is highly subsidized, highly saying lot of treatment which is done at Tata cannot be done in any government hospital also. So you cannot blame the system because they had, but you need, so it's like we also have to do something. You cannot rely entirely on the government to do everything for you. So I thought that since I was at St. Jude, then I'd seen the system of raising funds and this thing like in St. Jude, the LSAC does. We thought, why can't we do that? But this I'm talking about that era when there was lot of red tapeism. So when I went to the director that time and the management that let us start a foundation through which we can raise funds, they were very simple. This thing that they thought that since the government is giving crores of rupees this as subsidy to Tata, it will look bad if you start raising funds, and they will not like the idea of raising funds when you are already helping. So they were also right in their this thing, but I knew that something is we have to do. So they tried to help and all. They gave more funds also to treat, but we couldn't start the foundation that time. But later, when Dr. Badwe became the director of Tata Memorial Center, we went again and then requested him. And by that time, even India had started becoming progressive. So he was the first one to give us the permission to develop or start the foundation, which we have called Impact Foundation. Impact is an acronym for Improving Pediatric Cancer Care and Treatment. So Impact is the acronym for that. And through that, we saw that even if you give full treatment free, the patient cannot. We had around 25% loss to follow-ups or treatment abandonment rate. That means they will start the treatment, but in between either leave, or some people couldn't even start the treatment once we told them that they have to stay in Mumbai for 7 months or 8 months and all. So we had a lot of loss to follow-up. So what we did was not only free treatment, so raise funds for the children, but we also started arranging their accommodation, the blood, like I told you, the blood and blood products we started raising through the foundation. We started giving them nutrition. So all the patients who come to our OPD, even today, to get in the afternoon full lunch, they and their caregivers, and one in the evening snack. So that even today now, more than 15, 20 years now, we are giving that, so that the education for the children, so that we all started. So slowly we have, then the most important thing, that is again another thing that we learned, is by working with this thing called Jeev Daya Foundation. Actually, Dr. Jain was from US. He had started this Jeev Daya Foundation, but when he came to us, he told he has funds. He won't give 1 rupee for the patient care, but he gave us funding for things which we don't. This I'm talking 20 years back. We never imagined that that was required to take care of children, and that was data managers, medical social workers, nutritionists. See, these occupational therapists, psychologists, see, these are the posts which are never there in any good, even good medical colleges or institution like Tata also did not have this position. So we had one MSW for the whole, or two or three for the whole hospital. So we got funds to have our own social workers, own data. See, he was very simple. Unless you know what you are treating, and what, even tomorrow if you go to ask for help to somebody, they'll ask, who are you treating? What are your outcomes? If you don't have that, how are you going to? So he started giving us funds for data managers, social workers, nutritionists, psychologists, and one more. So basically, that was the paramedical staff, and that made a very, very big difference. So, and he had told that he will give only for 3 years. After that, it's your this thing. So basically, after 3 years, he stopped. But by that time, we had our foundation. So that to date, we have nearly 30, 40 people working for us for the pediatric department just to do this, so that we don't lose any child in between. And because of this, our loss to follow-up and abandonment rate has decreased from 25% to less than 5% consistently for the last, maybe 7, 10 years now. And this will happen because there are some patients or the families who can really not stay in Mumbai or take treatment, so that it will never become zero anywhere. So it has come down and it has remained like that for many years.
Yes, sir. So, firstly, so congratulations on the wonderful work that Impact Foundation is doing, and so the difference that it is making is palpable across the nation. So,
Yeah.
3 years ago, when I came to Muzaffarpur, so even at that time, we saw patients
Yeah.
being helped through this foundation. So, it must really make you proud. And
So,
since you are one of the
we
foundational
we
members,
have a
sir,
great team actually. So we have Ms. Shalini Jatia, who is our officer in charge, who works day and night for this foundation. And I always tell, we started with a few lakh rupees, but now we raise nearly 60, 70 crores a year. Initially, we used to help only patients from Tata, but now we have 5, 6 other centers across the country. That means all patient children taking treatment in Guwahati, in Varanasi, in Muzaffarpur, in Mulanpur, anywhere that Vishakhapatnam, so anywhere the children are, we are there to help. And this foundation is for children. So it is for children taking treatment at Tata Memorial Center. So it is not like Tata Memorial Hospital, it is for the whole center. And that is why any time, and we very importantly, we not only give funds for treating the child, but very importantly, what we learned from Jeevdaya Foundation is to give funds to have this paramedical staff, which unless you have that, you will not be able to take good care of the children. So that we have been doing. And like you told, not only after seeing the success in Tata also, now nearly every disease management group has started this type of thing, and it has helped head and neck cancers. Breast group was there, breast and women's cancer initiative was there even a little before, a few months before we started. But after that, we have neuro group, we have head and neck group, thoracic group. So a lot of other people have started working in this thing, and it has overall helped to improve the outcomes of children and other patients across the country. And like you told, not only Tata, looking at the success now, this has been replicated across the country in different pediatric cancer units.
so I heard Manipal Hospitals has also adopted a
Many,
similar
many
model.
centers here. And this was presented in the SIOP, that is the International Society of Pediatric Oncology in the UK, when we had the annual meeting there. This got the first prize when this was presented, and this model got published also in Pediatric Blood and Cancer Journal. So across the world, actually, people have taken note of this model, and many other centers are also doing it, because see, in US they need funds mainly for this thing, and some accommodation. Other things they don't need, but we needed so many other things also. So our model is more holistic than any model before that.
So in head and neck cancer also we face treatment abandonment. So here in Muzaffarpur we are yet to be able to solve that problem. So any tips for us or any advice for us?
So I'll tell you two things I did after I came back from USA. The first thing definitely was pediatric cancer, because that was the reason why I came back. But other than that, at the same time I started going to a rural outreach center, which is nearly 300 kilometers from Tata Hospital, that is Mumbai. This is in Chipurun in Konkan area. It is called the BKL Valavalkar Hospital. That's a at that time when I started, it was started in 96. I came in 97. I started going there. It was rather a 20 bedded ground structure, not in one story, ground story structure, which was there in basically rural area, no infrastructure, no this thing. But we thought there was a lot of cancer patients from Konkan areas to come to Tata Hospital for treatment, and many of them will come and go away, not take treatment, because initially Tata had this around Tata was a Parel and all, which was called mill area. So lot of these people working in mills were from this Konkan area, so they had houses surrounding Tata in Parel, Lower Parel area. So they would come and stay with these people and then take treatment at Tata. But slowly the mill, the mill strike that happened during those days, after that all the mills were closed because of, the mills were closed, and then people started no jobs, so they would, sell all the house that they had there, go to far off places like Badlapur and, remote areas, Mira Road and all, which were 40, 60 kilometers away from Tata Hospital. And when this patient used to come from there for treatment, they would come, but first day they cannot come in train, so they had to come by cab. Even if the full treatment is free at Tata, at least 1,000-2,000 rupees they needed just to come every day. So they'll come for a day or two and then just run away. So we knew that this patient required treatment at the doorsteps. So luckily, the Valolkar Hospital tied up with us. Now it has become, for last many years, it's a rural outreach program of Tata. So we went there and started treating the patient there. And what we did, so even initially there were no funds, so we started developing treatment models that would be done. And I work a lot on what we call drug repurposing. So where we use drugs which are used in medicine, not as oncology, but say for example, metformin, which is a diabetic agent, can be used for triple negative breast cancer, or basically celecoxib, which is anti-inflammatory for head and neck cancer. So we started doing that. But even then, like you told, when treatment we will develop for 150, 200 rupees per month also. But for diagnosis, even today, Ayushman Bharat or Mahatma Jyotiba Phule, or for that matter, any state schemes do not cover the cost for initial diagnosis. And as you know, now the cost of diagnosis is becoming more and more expensive, because people are not only doing CT, MRIs, PET scans and all, but also molecular testing and all, which runs in thousands, if not lakhs of rupees. So what we have done in say the PKL Valolkar Hospital, is we have raised funds through various mechanisms, either through ourselves, or some people have donated, or there's a Dr. Arun Kurkure Fund, which is the fund of the Indian Cancer Society, which gives up to 25,000 rupees. And we have again for our Lions Club also, basically of Greater Mumbai Marine Lines. So there are various organizations through which we raise funds for the initial diagnosis. That is up to 25,000 rupees per patient. But what was happening even in Valolkar Hospital was that patient would come for with a this thing of diagnosis of probable cancer, but once they were told that these are the tests to be done, they would run away. So now we make sure that through this fund we do all the initial tests free of cost, and once the diagnosis is done, then the schemes help out with the this thing. So I think the new thing that the organizations which were helping initially for cancer treatment should now change focus and give funding for the initial diagnosis. Then it will make sure that people will not run away. And that's what we do through Impact also. So for children, for the initial diagnosis, the day they'll end up in Tata Hospital or any HBCH here or any other hospital, is we put 10,000 rupees in their account, so that they don't have to even spend 1 rupee for their initial investigation also. So unless you do that, even if the treatment is free, if they run away during the diagnosis, you have lost a child and you lost a curable cancer. So that is what will be required. And I've been telling even the Indian Cancer Society, and they've done to a large extent, that this is a changing or shifting goalpost. Yesterday we required funding for the treatment. Now we require for the initial diagnosis. Change your goalpost. Help out with the diagnosis, and it is at a fraction of the cost. See, like Indian Cancer Society gives 4 to 5 lakh rupees per patient for treatment. You can give 25 to 50,000 per patient for this thing. You can even cover more patients.
Yes, sir.
So treatment will be taken care of by the government scheme. Change of focus. So they are also doing it, and they have helped us a lot. The Arun Kurkure Fund has helped a lot because of that, in the Valhalkar Hospital, we are now making sure that no patient goes away without a diagnosis.
So we've heard that you visit the Valavalkar hospital every 3 weeks,
Yeah.
despite your busy schedule. So what is your connect to the
See,
place?
again, I don't know if anyone of the young generation know who is Cassius Clay. Have you heard about Cassius Clay? Okay. Have you heard about Muhammad Ali?
Yes, sir.
So Muhammad Ali is Cassius Clay. Basically, he
Okay.
changed his name. He was the world heavyweight
Yes, sir.
champion,
Yes, sir.
boxing
Yes, sir.
champion, and nobody could. Up till now and in the future, I don't know if there'll be a better boxer. But he had told years back that voluntary work or social service is the rent that you have to pay for your existence on this earth. So I really feel that many of us, I think, let me retire, then I'll do social service, I'll do voluntary work, I'll have more time there, I'm so busy now. But so many times we go across the country to give lectures, which doesn't make a difference. You go there, talk, give one talk, they'll clap, everything, they'll say great talk. But after that, it's not going to make impact. But instead of that, I've been since the month I came back from USA 97, July 1997, I've been visiting this hospital every month of the third weekend, and this is because my spiritual guru, actually, he is from that area. We have the organization there, so through that I've been going. But because of that, now thousands of patients, literally from initially you'll not believe, the first few months I used to see 4 patients, 5 patients. 3 days we didn't know what to do with the time, and now we see around 200 250 patients each time that we go, and we don't have time to eat also. So it has changed. See, people, if you go consistently, so always another, actually, St. Jude's Child Care Centers in India, that is an organization called St. Jude Child Care Centers, which is actually formed by Mr. Nihal Kaviratne, who was the chairman of the, not Hindustan, but the whole Unilever this thing. So he once told me, that the charitable organization does not mean that you have to do charity. It has to be run professionally. So if you have given that commitment that every third weekend I'm going to be there, come what may, whether it's rain, it's this thing, there's a ESCO meeting, there's a this thing, I've never missed this thing, and I've been going there, and that has made the difference because now patients also know that come what may, if it's the third Saturday, the OPD will be there, so they come without this thing, and that has helped to end. The most best way to get more patients is your own patient, and it doesn't have to be the cured patient. Even the patients who have died, their relatives have brought patients, and they still bring patients. The social workers who know that you are coming there regularly as senior work, they bring patients. So from 4 and 5 patients, now we see around 1,200 patients, new patients a year at that place, so that all these patients can get treatment at the doorsteps, and without, like I told you, money is not a thing. If they don't have money, we raise funds, we give free treatment, because it's a charitable organization as it is, but we make sure that all patients who come there are treated free.
Yes, sir. So then I think it is our responsibility to advocate for more
I
funds to our patients. Yes,
And
sir.
don't wait for government. My
Yes, sir.
thing is, don't wait for the government. See, government does, but what government can't do, don't wait for somebody to do it or start complaining, "Okay, I don't have funds."
Yes, sir.
Like I told you, we did not have funds initially when schemes were not there to treat. So we made sure we developed treatments that were cost effective and were doable in that area with the infrastructure also, because you cannot give intensive treatment, and we used to come back. We gave the treatment and came back. Local doctors will take care of the patient. So we had to make sure that we do not lose patient because of toxicity. So we developed treatment in such a way that it could be done locally. The local doctors will take care of the patient. Luckily for us, by that time, mobiles had come, this thing, so communication was much easier. So we used to be in constant touch, but because of that, we had the courage to do that type of treatment. And now, though, it's a full this thing. from 20 bedded now it's a 650 bedded hospital. It's a medical college now. It has a broad specialty, this thing.
Nuclear
Right.
medicine as well,
Yeah.
sir.
So
I heard
right
going, sir.
from CT, MRI to two linear to radiation machines we have. We have a PET scan and nuclear medicine department. So slowly, and again, don't start all of this on day one. So slowly, as the need, this thing, so that it doesn't go waste and it doesn't put a burden on the organization also. Because one day, government has funding, you'll get 350 crores, 400 crores to start this thing. But that type of thing, funds, organization will give you in the upper. So start with 20 bedded, make it 50, 100, this thing, and as it expanded, slowly the infrastructure got this thing, and that helped to basically develop everything there. Now we even have MD radiation therapy there. Not yeah, MD radiation, not in DNB. MD radiation therapy is there. Everything is there now. MD medicine, surgery is the whole thing, but it developed slowly. And again, like I told you, don't wait for government to do it yourself. And that another thing that government has done, which we don't talk, but the thing that really helped even this hospital to come up was basically the CSR.
Yes,
I
yes,
mean,
sir.
making it mandatory to do CSR has also helped a lot for developing the healthcare system in the whole country, actually, and we are no exception. We now raise 70 crores not because we really fight with for every rupee, no, because of CSR funding. And if you do good work, organization will come and help you. And many of our organizations have come year after year to support us because they have seen the work. But a lot of support we are getting, and even this hospital has got, is through the CSR funding, and we have to thank the government for making it mandatory to do that, because otherwise it would not have been possible.
Yes. So you've been very vocal about metronomics and metronomic therapy since 2012, 2013. So you were much ahead of the curve, I think, because only now it is getting adopted into routine practice. So where did that idea originate from?
Yeah, there again it's a big, I go to this place where it's in Konkan, that is the belt of Shivaji Maharaj, and there, Ganimi Kawa, I don't know if you have heard the word. Ganimi Kawa is basically was a method of Shivaji Raje to basically how he will, Shivaji Maharaj had such a small force, Mughals had such a big, but still he survived. How? He will never attack the enemy directly. He will cut off their water supply, cut off their food, this thing. So basically, metronomic therapy is not to kill. See, war against cancer, we are talking war, but war doesn't, we have not won the war. So never go for it, war for anything. But we have, instead of attacking the tumor directly, we change the microenvironment. See, cancer grows in the tumor microenvironment. If you can modulate or modify that microenvironment, it will be better to take care. So, what the theme or the this and it is, see, metronomic was there outside also, but their metronomic was using the same molecules, methotrexate and doxil. For every cancer, they will do that only and this thing. But the one which we have developed is basically it's a system where we have three principles, three medicines that we use. One is basically some drug to kill that particular cancer cell, though not kill directly, but through this thing. So not like a maximum tolerated dose, but in a different. So one thing to kill the cancer cell, one to change the microenvironment of the tumor. For example, in head and neck cancer, there's a lot of inflammation. So you basically have anti-inflammatory there. In triple negative breast cancer, there's mTOR, this thing, so it suppress mTOR inhibition. That's why we use basically the metformin there. For each cancer, for angiosarcoma, we use propranolol. Propranolol is the anti-angiogenic this thing because it was used in hemangiomas. So we use propranolol there. So each this thing, so one to attack the tumor, one to change the tumor microenvironment, and the third very important is to modulate the immunity. Now you'll say immunity is all these checkpoint inhibitors and all. There's so much about basically nivolumab and pembrolizumab and all these are immune this thing. But the difference, the CAR T cells for that matter, all these are immunity drugs, but they attack the positive immunity. That means all your pembrolizumab, nivolumab, they take care of the stimulatory immunity. But there's a very, very different and very important component is what we call the inhibitory immunity. So your T regulatory cells, myeloid-derived stem cells, macrophages, all these are there in the tumor microenvironment because of there's a lot of hypoxia, a lot of acidic this thing, lot of inflammation. When you have that, you get all these negative immunity cells in the tumor microenvironment, and unless you modulate that, even your checkpoint inhibitors don't work. And that is why if you see why do checkpoint inhibitors and all work only 10-15%. The remaining 85 doesn't because the tumor microenvironment is not conducive for this thing. So our principle in metronomic, the one which I use at least is three-prong approach is one drug to kill the cells if possible, one to change the particular microenvironment which is common for that tumor, and the third one is modulate the inhibitory immunity. And this, when you use a combination of this thing, we have had excellent results in many cancers. We have done, see, we started with the common cancers in Derwan. Again, that how it started was Madam Dr. Dinsha was the director that time told me I will not give any funding for chemotherapy. So we had to develop ways and means how to take care. And the commonest cancer there was head and neck cancer, triple negative breast cancer for a change, ovarian cancer, cervical cancer. So we developed methods or combinations for this common cancer which worked very well there. And one day we had a visitor there, Dr. Anil Kakodkar Saab, who was our chairman at that time of ARB and this, and he visited that place, and then we showed that data, of this thing. He didn't tell us anything, he didn't tell me anything. Came back and asked Dr. Dinsha, actually, what is this metronome? She didn't know. She what? No, Dr. Banavali was there and I just saw it. This, why don't you do it here? So after he left, she called me and told, Hanali, what is this metronome? I told her that this is what we do. Why don't you do here? So I told here we have a disease management group. And our commonest was head and neck. But luckily, Dr. Prathamesh Pai, who was in the head and neck unit, his resident was the one who had worked with me in Derwan, a surgeon who had worked there. So Sachin Mani, who has worked with me in Derwan, had joined Tata as a resident. So he was there, so he had told Dr. Prathamesh Pai, and then we all three agreed, and we started working, and the results which we had were so excellent that now it has so slowly from two, at that time there was no checkpoint, no EGFR inhibitors. So we started with celecoxib because there's a lot of inflammation in this thing, and methotrexate not only to kill the cancer cell but also to modulate the immunity. So we started with two drugs, but then when the EGFR inhibitors came, we added erlotinib because we saw actually what happened. We started with two, when slowly the patient will become resistant to treatment, and luckily when this gefitinib had come, and when we added gefitinib, we would see again good responses. That's how the third drug, first gefitinib, but then erlotinib came, and we started using these three drugs. And from there, we have now gone to basically even using chemotherapy along with that and the checkpoint inhibitors along, and that has really. And I always say that, basically all these checkpoint inhibitors, nivolumab and all these are Lamborghinis, the Ferraris and Lamborghinis, they are so expensive. But an expensive car, if you make it run on a road full of potholes, it's not going to run at all. So if you want those Ferraris to run, you have to first smoothen the road. And that is what our metronomic therapies does. Is basically it smoothens the road so that your Ferraris then can run. So now we are using metronomic along with the low dose, again low dose. Dr. Kumar Prabhash, Dr. Vijay Patil, and now Dr. Akil Kapoor, they have made it great, this thing. So now when we use together, I have had patients who had no responses go into pathological remission when we use this together. So it's a very, very effective combination, and that I think it's going to change the way we do. And my ultimate this thing is, and that's what we did along with Prathamesh Pai, to give neoadjuvant therapy and then do the surgery and then give maintenance therapy also. So that's going to be the future of head and neck cancer, at least, and other cancers we are already using maintenance therapies. But maintenance therapies, especially the metronome maintenance, will become part of treatment, because see, our most successful treatment protocol in medical oncology, pediatric oncology, is the treatment of childhood acute lymphoblastic leukemia, and there we use 2.5. Even though we have MRD negativity in 15 days, we give 3 years treatment, and that is 2.5 years of, or 2 years of maintenance therapy. So
So,
that has a major role to play. So slowly things will change, but it's a good way of changing the way we are treating cancer now. And again, like you asked, you can't win any war. Actually, you have to treat it with knowledge. Always say no cancer, which is KNOW also, and NO also. No cancer
yes, that
through
makes
knowledge,
sense.
not
Yes.
through wars and all. Moonshots and all. There, first do the earth shot. Moonshots are much later. Let us do what we can with what we have, and that's another thing that I learned in pediatric oncology, was that using the same drugs which were used in 60s and 70s, no? Same prednisone, vincristine, adriamycin, doxorubicin, L-asparine, these all drugs were there in 70s also. That time the cure rate was 0, 10%. Using the same drugs, using it differently, from 10 we have gone up to 95% cure rate. 95. We don't need a new drug every day to cure cancer. If you know how to treat, how to use the existing drugs also, we can improve the outcome. Problem is in adult oncology, especially since they are like children, they need a new toy every day to play, and before you know how to use it to the full extent, a new drug comes. So they leave this and then go after the new one. That should not happen. Luckily for us in pediatrics, you cannot use any new drugs. That's because it, unless it's used for a long time in adults, you cannot use it in children. That's really helped, pediatric oncology to use effectively and through knowledge and through teamwork. Because pediatric oncology, we treat children on protocol which are multicentric, and we come together and do. That has helped us improve the outcome using the same medicines that we used way back in 70s and 80s.
So you spoke about multi-centric research. So whenever we look at landmark studies done in the West, so they always involve a lot of centers, and sometimes that seems very daunting to us. So collaborative research, what do you think is the scope in India, and what has been your experience?
Yeah, one thing, we cannot blame our people, because in USA and all, there's a lot of funding for this.
Yes.
Still in India, like again CSR and all, when we do that, we get a lot of funding for children, treating the children, treating patients. Why children, adults also. But the moment you tell them we need funding for research, very few come forward. So still in India, research means experiment. Research is not experimentation. You have to take that in account, that if you want to improve the outcome of any disease, you have to do, treat multiple hundreds of patients, look at their outcome, see where we have failed. I always tell my students also that don't look at where you have succeeded to formulate a protocol. Look where you have failed. If you take care of that, then your outcomes will improve. So that, to do that, you need to treat hundreds of people or patients on a single protocol, and for that you require funding. Not only now with the our new rules and guidelines, you cannot, if it's not standard of care, you have to arrange for the whole funding. So it becomes very daunting and very expensive to run protocols, and that is the reason, I think. But still, we have organizations like ICMR now, DBT, and even our NCG. We have a National Cancer Grid at Tata, which if you tell a protocol of involving at least 3 centers, they fund it. So there are more avenues to this thing. But the main reason why in India this multicentric and all has not come, because of lack of funding. If we had funding, or even today we get, so we have done a thing called icicle protocol, which is a ALL protocol, multicentric, started by Dr. Vaskar Shah when he came from UK, and we already had a MCP 841 and 842 protocol, but that was in 3 or 4 centers only. So he thought, why not do it in more centers? He came, we started this icicle protocol, treated nearly 4,000 children on a single protocol. So all that can be done, and this thing, we got funding from NCG, from ICMR. So slowly we did it, but again, we need funding. So, and people have to understand that doing research is not doing experimentation. It is ways and means to improve the outcome. As important as to fund for the treatment, it is important to fund research also.
Yes, sir. So Tata gives us this mandate of service, education, and research.
Yeah.
And so sometimes as clinicians, we fail to find the right balance, and we struggle with it on a daily
Yeah.
basis. So any advice from you on that front?
Again, I'll quote Dr. Badwe sahab. So Dr. Badwe always feels that people always crave that they don't have time to do research and I know this thing, but he always tells that the most fluent researchers are the ones who are the most busiest. Take for example, Dr. Badwe was there, Dr. Kumar, Dr. Anil De Cruz, all these people, Dr. Sudip Gupta. These are very, very busy clinicians, but they are the ones who he always feels that the more busier this thing are the ones who do. Then you have to have that extra, this thing of doing research. It also requires a flair actually. It's not a cup of tea for everyone. But those who are good clinicians also become good researchers also. So you have to take out extra time. And I think if you do that, and once you do one or two protocols, then you'll be in this thing of doing more and more research. So it's important to have that inner passion that I want to. And all this comes from, when I told one of my colleague from ICMR and this thing, and she was very against this thing, ki you all want to do research because you want to get publications, you want to get name. Because this is when we told that, in between there was this thing that even standard of care should be funded. You told it this way, research will never happen, this thing. But the some people have that thing, we do research mainly to get name, publications, and this thing. It's not so. We also want to help patients. We want to find out cost-effective means of treating. We want to find out ways to improve the outcome. So why should I be happy with 70%? I am not happy with 70%. I want 95% outcome. If possible, 100%. The person I worked with at St. Jude is Dr. Chinghong Pui, who is considered the father of pediatric ALL, childhood ALL. World over, he has maybe 1,000 papers only on ALL. But he once told when is the outcome, when I was there at St. Jude was around 78%. When I came back and when he visited Tata, the outcome had increased to around 89 or something percent. I told, sir, you are a very happy outcome. And that is why we want to work, but people have to support that now.
Yes, sir. So even if we are able to make a small difference, it is worth it.
Absolutely,
Yes, sir.
absolutely.
So we know that you've helmed the Department of Medical Oncology and Pediatric Oncology for a good few years. So what, according to you, was your biggest win during that time?
Biggest win was to keep the people together. See, when I joined, two things, I will say two things. One, Dr. Sudeep and we actually developed a method of how to pick up drugs. See, your outcomes depend a lot, especially in a country like India, the quality of drugs and all. So when we this thing, and any government organization has that L1 thing and all, so through Sudeep's idea, mainly of Dr. Sudeep Gupta, we developed a mechanism by which we could select the best drugs. So that was the one of the first things that we did when I became the head of the department, which runs till today, and we make sure that the drugs that we use are of good quality. But the second thing that happened, fortunately or unfortunately for me, was when I joined the new thing at Tata we did was a disease management group. That means no person can treat more than one or two disease areas. Like Dr. Badwe was an excellent thoracic CA esophagus surgeon, but he had to give up when he took up breast cancer. So many of us gave this thing, So I was pediatric oncologist, but once DMG came, I could treat only pediatric leukemia, lymphoma, blood cancers. I couldn't treat pediatric solid tumors. So all of us had to sacrifice something. So that thing when happened, there was a lot of friction within department and this thing. So I think my main contribution is to keep my whole team together and without having major fights, major this thing, and we really gelled well. So I think a lot of help from my colleagues also, but together we walked through that phase. We thrived, so a lot of good work happened. in this thing. So I think overall, it became a good teamwork, and a lot of good work came out of that phase.
Okay. So you said you've been associated with the Tata family for more than 35 years, sir. So was there any moment where you faced maybe transiently a period of frustration or dissatisfaction and you wanted to leave? Was there any moment at all,
Leave,
sir?
leave never, because I always told, when I came back from US, my daily pay at in US was much more than my monthly salary in India. I always say
Yes, sir.
that. So it was not for money or this thing, but one thing, when I came back, like I told you, I was very disturbed with the cost of treatment, and patient couldn't. So patient at that time would, when they would come, if they had no money, they will take out loans, this thing, but treat, and then apply for various funding. So this happened, they would apply for Prime Minister's Fund or any other trust. Various trusts gives money, but it takes time. So they would get the funding, but that will come after 2 3 months, and they would have spent the maximum, as you know, treatment is for the initial diagnosis and the first month, what we call induction treatment. So they would have spent a lot of money. So when the money came, I would asked the management to reimburse the old bills. They were allowing at that time. But then there are certain people who came and even told me that we know why you're doing this, you are getting cuts and all. I mean, I never felt like leaving or anything, but I will tell them, you think what you are, I'll do what is needed for my patient. But people, I've been told that I must, I take cuts and this thing also. So that was, I won't say low side of this thing, but I faced all that. But one thing is for this, if you have come to help patients, I don't need people can tell anything. You have to be true for yourself. And if you know you have not done anything, there is somebody up there who actually takes care. So from that phase to, the day we started Impact, and now that we are helping, it's been a long, long journey,
Yes.
but very fruitful journey. And we are happy that through all the help that we get, not only from various CSR funding and all, but even NGOs. Multiple NGOs are working. It's not a one person or a one impact foundation. There are at least another 15 cuddles. There's an organization which just gives nutritional support to patients. St. Jude's gives accommodation support. Save a Life gives blood platelet support. So there are organizations which have taken up one area, and through that we have been able to do what we are doing. So lot of teamwork, lot of help from, and I cannot forget even the simple volunteers who come and work with us. Every day some people come every day, just sitting outside checking what medicines these children are taking, so that inside we have a list already. Simple thing, they sit outside and make sure. Then inside it becomes so easy for us to know that this right medicine is taking, right dose has been taken. So there are volunteers who come and just sit for hours in the outside OPD just to do this. So lot of people have come and helped us out, and lot of work we are doing has been done because of a teamwork and support from various fields of
So, so, like you said, when we are seeing patients in the OPD, so every decision that we make leads to some difference in their survival or some difference in their quality of life. So, even though we try to give our best every day, there are occasions that we fail. So, we recently had an incident where one of our post-op patients had a bleed in the ward, and we were unable to get there on time. So, have you ever felt like you have failed a patient, and has that responsibility ever been a weight for you?
No, it's very, again, I believe in spiritual this thing. So I have a spiritual guru, and it helps in life. So I used to get worried even a single patient would fail, because first of all, childhood cancers are very curable and they do well. So whenever there has to be a, either an infection death or induction death or a relapse or this thing, he will take it personally. But then one day he understood. I did not ask any this thing, but he one day, luckily I was alone with him. He just sat and told me that it's in your hand is to do the best that you can. Don't worry about the results, and if you do that, then it will get affected. And if you are affected, the your working will get affected. So don't take it personally. Do the both ways. If they are cured, also you should not feel it's because of you they are cured. But worse also, if they fail also, it should not be your this thing, and that has helped me a lot. Because if you don't do that, our field is such that burnout can be very, very easy, and people lose, the enthusiasm to work and all if they are burnt out. So I think best thing to do is both ways actually, not be elated also with your successes and not be disheartened also with the failures, but do the best. And that is why we never, like I always tell it, Tata, that Tata culture people say, but that's because the first patient that comes to the hospital we see, and the last patient, irrespective of whether it's 5 o'clock, 7 o'clock, 11 o'clock, we don't worry. I mean, we just give the best that we can. And if you do that, I think overall it helps for your sanity also, and it improves the overall outcomes also, I think.
What are your plans for the future and what other projects can we look forward to?
No, my thing is still, this metronomic
Yes.
therapy is my this, and there's a lot of work to be done. So, like repurposing, I've actually done for 5, 10 drugs, but there must be hundreds of drugs out there. Which this thing, I always tell my colleagues, my students, look out for this thing, and if anything comes out, let us know. We can explore that.
So you mentioned metformin for TNBC. So any other drugs you would suggest that we should look into?
We have metformin ka data. I have 97% outcome for TNBC using combination. Again, combination. It's not this thing, but methotrexate, metformin, and endoxin we use there. Head and neck, like I told you already. In ovary we use etoposide, tamoxifen and endoxin. All this is published, so it's not this thing. Then in angiosarcoma, we have a very good combination of basically propranolol along with others. This thing. So cervical cancer, we have so various cancers. We have good data, but there are many, many more drugs out there which can be explored. So we need. I did a international metronomic therapy meeting where we called people and made them present their work also. So it's like that. We should have meetings at the national level, maybe that was the international meeting, so that people can come and present their work. If there is some good lead you can get from there, then we can do it as a study and this thing. But a lot of this drug repurposing work has to be done, and I feel that we should be doing more of this work at the national level, and basically because this is need of the hour. And I always tell that let the West explore drug discovery, because drug discovery also is important, but a country like India should be looking more into drug repurposing, because not only the cost is low, you can use it in the clinic the next day. And if you start drug discovery here, maybe 10 years behind, you're starting drug repurposing 10 years ahead. And the cost is low, the side effect profile, everything, so it will be much easier to do that way.
Yes.
So I still feel a lot of work is pending in this field of metronomic therapy, and now combining metronomic therapy with checkpoint inhibitors and your regular chemotherapy, that is how it will be the future of oncology.
Yes, sir. Thank you so much, sir. It has been
Thank
a
you.
privilege to spend 1 hour talking to you. And,
Thank you.
sir, I have learned a lot and I look forward to reflecting on it.
No, I think, one thing is that don't feel overwhelmed with what, and you all are in that age also and in the environment, because there are thousands of patient centers. So, and in this period, the more you do, or basically more you work, more it will help you in future also to get ideas to this thing. So I think one thing that I would say any young oncologist or a medical this thing is, don't look at the hours of work or the amount of work, or he is not working that much, why should I work? That happens in any place where you work in this thing, that he or she is not working, why should I work? Keep on working, or this thing, you will be, the best satisfaction is you yourself will feel happy. So I had one of my friends actually, who is a very flourishing practitioner, who took me when I went to his place for a meeting. He took me first in a BMW, and while coming back, he had the latest sports model of Mercedes, and he told me, see, these are my toys, and I get thrill of this. So I told him, the day I get a good response to metronomic therapy, that is the thrill I get, when I can work in 100 rupees and I get this thing which you're money doesn't get. That is the thrill I get. So to each his or her own. So don't compare with anyone. Be happy with what you are doing, and have that passion to try to help others as much as possible. That will give you the satisfaction of being in this field, because we are in the field of medicine where we can really help, or we have the occasion of the chance of helping so many people without even asking. So I think do that, and you'll be, you'll really be happy, and you'll have a great night's sleep. I always tell that I can sleep standing also, because there's nothing to keeping in mind, or basically comparing with anyone. That actually brings us down. So don't do that. Enjoy your work and think of how you can help others. Good things happen.
Yes, sir. Yes.
Thank you.
Thank you so much, sir.
you.
Thank you so much for
Thank
joining
you.
us. Thank you.